There's a question almost every physician building a high-ticket practice asks themselves quietly in their practice, in the parking lot, at their home, after a patient hands them a $15,000, $25,000, $50,000 check. And that question is what I'm doing predatory? Is this something that's even ethical? If you've not asked that, you should. And if you've asked it and dismissed it without really sitting with it and kind of contemplating it, you should sit with it and actually think about it. And if you've asked it and you've sat with it and you ended up being paralyzed, unable to change what you're actually thinking about yourself and your worth and how much your work is worth, ultimately it can be a stuck that will hold you back from growing your practice. And ultimately there are systems that help you scale. But if your psychology is beating you down, then this is a challenge and this has to be addressed. So I'm Dr. Isaac Jones, and I've worked with people that have invested $15, $25, $50, $100, $200, $300 plus $1,000 working with me in one-on-one programs and group coaching programs as well, obviously lower ticket than in the six figures. But over the next 15 minutes or so, I'm about to show you how to overcome this moral objection that nobody on YouTube or anywhere else wants to address head on. Whether high-ticket longevity medicine programs or regenerative medicine programs or just health programs that are helping people reverse disease and get better is actually ethical. And what is the honest critique about this? And what are the reframes that we should have around this? So how is it that operators with integrity, intact resolve in their practice while they're charging quite a bit of money? So let's get into some of the objections, right? Let me start by giving the objection at its full strength, because the worst version of this conversation is the one where the objection is strawmanned and it's essentially dismissed. So the objection has essentially three legitimate components. Number one is access. When a primary care physician converts a $10,000, $15,000, $20,000, $30,000, $40,000, $50,000 a year membership patient, the thought is they're gonna lose patients and there's other people that won't be able to pay the fees that will enable them to work with me. And so here's the reality, is multiple peer-reviewed analysis have documented this. 2024 literature review in PMC, a concierge medicine impact report, described that the concern that practices have and practice owners have, where they feel that, man, I'm disproportionately directing patients of color or for those with lower socioeconomic status or individuals with more significant health concerns towards a model that's broken is not going to get them results towards the traditional primary care system. In 2017, there was also in the American Journal of Medicine, they noted that concierge practices on average see fewer Medicare and Medicaid patients, fewer minority patients, fewer patients with chronic conditions like diabetes, hypertension, etc. And so that is something that is the reality. But also something that is kind of in the head and a voice in the back of a lot of these doctors and practitioners' heads. So distortions are another challenge. Critics argue that the model creates a two-tiered system. There's wealthy patients receiving comprehensive preventative care, and then there's the low-income patients receiving rushed appointments in an under-resourced system. So I can't wait to address these challenges, but I'm just kind of setting up the challenge, the psychological issues right now. There's St. Joseph's University's Institute for Catholic Bioethics framed it as a justice question, right? So if there are medical interventions that benefit concierge patients and these are prescribed for some but not others, failure to treat all equally violates the basic tenets of justice to essentially treat all people fairly and equitably. The third objection is complicity. When you charge $15,000, $20,000, $30,000, $40,000 a year for a service that the public healthcare system is supposed to provide, which is absolutely true, you're arguably profiting from the system's failure rather than fixing it. And every physician who exits the conventional system into a high-ticket model marginally reduces the supply of clinicians available to the broader population. So these are not bad faith arguments. These are not knee-jerk, arguments. They're real ethical concerns that are articulated by serious bioethic individuals, peer-reviewed researchers, and physicians who have thought about this very carefully. And if you're going to do high-ticket practice, you owe it to yourself and your patients to engage in these arguments seriously, not to dismiss them. So let's engage with them seriously and get underneath them. I think it's important. So I'm going to get into how to reframe these and how to address them and how they hold up under scrutiny. So here's the reframe. I want to give it very carefully because most reframes of this objection are unconvincing. They sound like rationalizations because that's often what they are. The defensible reframe resets on 3 observations. So observation number 1, the alternative is not equitable healthcare for all. The implicit comparison the objection draws is between high-ticket private medicine or one side and a fair, equitable, well-resourced public healthcare system on the other side. Here's the reality. If we didn't have to do concierge, we wouldn't do it because the reality is it doesn't exist in the traditional system in the United States in 2026. What exists is a fee-for-service insurance system that pays primary care physicians at rates that have not kept up to pace with inflation, that requires 7 to 15-minute appointments that you can never get great results with, and generates 30 to 50% of the reasons why physicians get burned out. And it also produces clinical outcomes that lag behind other outcomes in developing countries, despite being the most expensive system in the freaking world, right? It's unbelievable. When a physician opts out of that broken disease care system, they're not opting out of a fractional egalitarian alternative. They're opting out of a system that was already failing and that is hurting people and is literally creating even bigger problems than what we're seeing in today's day and age. And I think is ultimately going to lead to the bankruptcy of many different systems in the United States, and maybe the United States in and of itself if we don't fix it. And so this is where the refusal to participate in this is very important. And the honest question is not, is your private practice exacerbating inequality compared to a perfect, system? The honest question is your private practice making things worse than the alternative that actually exists, which I'm hopefully thinking that it doesn't. And the answer to that, is really dependent on how you oriented and developed and created your practice. So number 2 is that there's a depth of care that is not zero-sum good, right? The objection assumes that the depth of care concierge patients receive is somehow being taken from the patients who can't afford it. And that framing only holds in a world where physicians' hours are perfectly fungible, where an hour spent with a $15,000 a year patient would otherwise have been an hour spent with a Medicare patient. That is not how labor economics actually works. And a burned out primary care physician seeing, say, 30 patients a day is not delivering depth of care to anyone. And they are actually delivering an average of 12 minutes of distracted attention to each patient, missing chronic disease management, preventative care, certainly functional and longevity care, and accelerating their own exit from ultimately medicine. So this ultimately contributes to the overall physician shortage, right? The reason why people are leaving the system, hemorrhaging out of the system right now is because of this. And a physician who builds a 60-patient longevity practice is not stealing depth from a public system. They're creating depth where it didn't previously exist. And the question is whether the depth is also being made available in any form, right? So to people who can't pay for the $10,000, there's other options for them that exist. The second question, What do you do with the leverage your private practice creates is the actual ethical question that you should be asking. It's not whether you build the practice, it's what you do with what the practice gives you. So the observation number 3 that I'll give you is outcomes are the moral object, not the price. The objection focuses on the price tag, but the price tag is morally neutral. A $200 visit that produces a misdiagnosis is worse ethically than a $15,000 program that catches every stage of cardiovascular disease and prevents a heart attack. The morality of medicine has never really been about how much a service costs. It's always been about whether the service actually produces health and addresses underlying causes. And the relevant data, studies reference in 2024 PMC literature, there was a review that have documented that concierge practices are associated with fewer hospitalizations, reduced emergency department visits, better control of chronic conditions like hypertension and diabetes. And Mendel in 2020 did research that found that concierge patients experience approximately 30 minutes faster door-to-door times and 40% reduction of emergency wait times. There's patient satisfaction that's much, much higher than the alternative. The adherence to health programs are higher. The early detection benefits of comprehensive panels, coronary calcium scores, advanced lipoprotein testing, like LP(a) and APOB, et cetera, multi-cancer detection blood tests. They are concentrated in the higher ticket population because that's where the panels are being run. That's what they're demanding. They're wanting that. And if your practice is producing better outcomes for patients in it, you are doing real medicine. And here's the other thing, is that when people pay more money, they pay attention. When people pay, they pay attention. And there's a moral and ethical thought that you want to have in that if you charge $200 for a 12-month program, they're not going to take it seriously. They're not going to come to follow-up visits, et cetera. If you charge what it's worth, they're going to actually value you, value the program, and they're going to get better results. So we have a moral and ethical obligation to charge what a program is actually worth. So whether the price tag is $200 or $15,000 is a separate question from whether the medicine is actually good. Okay, so let's get into the synthesis of all of this. The reframe that holds up is that high-ticket longevity medicine, regenerative medicine, or high-ticket programs for any kind of health prevention, concierge, functional medicine thing that you're doing is ethically defensible when 3 conditions are met. The care is genuinely deeper than what's available elsewhere. The outcomes are genuinely better, and the practitioner uses the financial leverage created by the model to extend access. You're gonna have more money, you're gonna have more time, and you can extend access to people through pro bono work, charity work. You could have downsells into group coaching programs where you could still work with these people inside the context of your own practice. So you can, ultimately you don't have to push these people away. Ultimately the content can reach a broader audience and impact people. So mentorship of junior physicians or system level advocacy could be something that you end up doing as well. And so when these 3 conditions are met, high ticket medicine is not predatory. In fact, if you get your message out there to the masses and they want to work with you, you can create those high ticket group coaching programs or those membership programs that require them to work with other people other than you. And my vision is that in America, we wake up to the fact that we should be integrating this into insurance. It is one of the few places in American healthcare where a physician can actually practice the kind of medicine they actually were trained to deliver. That is concierge longevity medicine. While remaining solvent and where the surplus of the practice generated can directly benefit people that are stuck in the system and need support. I'll never forget this. In my last event, one of the women came up to me and she said, "Since joining your program, I've never worked more in my life." And I was like, oh, that's not good to hear. And then she said, "I make more money, I have way more freedom, and it's made me want to serve more people that can't afford care." And she said, so now because this technology is so transformative, I'm getting it out to more people, helping more people, yada, yada, yada. It is so amazing. It made me cry when she told me that. She's up to like 10 or 11 o'clock at night reversing diseases because for people that can't even afford her program, because she's making so much more money with this model. So this is the moral case. It is not airtight. No moral case in medicine is airtight, but it's intellectually serious, and it's the case I would defend in front of a bioethics committee, especially if you can expand your offerings to group coaching and if you hire health coaches underneath you that deploy the program for less of an investment, then that solves it right there. So, how is it that top practitioners resolve all of the ethics in their practice? Because it's not just you, it's other people as well. You have to communicate this to your team. If you have a sales team, you have to communicate this to your sales team, because they could be thinking this in the back of their head. That's going to definitely impact conversions. Doctors could be thinking this in the back of their head. It could impact how they think as well. So the reframe is theory. What actually matters is what physicians do. The operators are watched. They build 7, 8-figure practices without losing their integrity. They tend to have 1, 2, 3, 4, 5 practices or even more. So here's the thing. They do charitable work, right? And some of that is inside the context of the program where they can make money off of group coaching programs that's more accessible to the masses. But when you make a lot of money, it's our responsibility to give back. We have built over 30 homes for families of 5 because of the surplus that we have seen come in, which is a huge blessing for us. And each home has an organic garden. It's connected to kind of a wellness facility, and it's also connected to commerce in different first world nations. And you can look it up. It's called newstorycharity.org, I think it is. Or newstory.charity. But I think it's newstorycharity.org. But you can ultimately do this. You can define a percentage of your practice that is reserved for patients who cannot pay. In some operators, they run this at 10% or 20% of their patient slots. And it's dedicated to scholarship cases. Patients identified through partnerships with the community health organizations that you have, or federally qualified health centers, or referrals from social workers. The scholarship patients receive the full program at no cost. What I recommend is get them to pay something, because what I've found is when they don't pay anything, oftentimes they can take advantage of you, and some of those are the worst patients that you have. But when they pay something, like even $10 a month or $100 a month, that's something that ultimately is meaningful to get them to move forward. Actually, New Story Charity found this out when they gave homes away for free. They realized that people would abandon the homes and they would abuse the homes because they don't have the psychological belief that they earned it. Right? It's very weird psychology. So in 2020, PMC review on pro bono work and health professionals documented that pro bono and charity work in private practices is feasible, it's sustainable when systemically built into the operating model. The physicians who build it in from the start can sustain it typically in the long run. The ones who treat it as an aspirational add-on really deliver on it. The number is not the point. The discipline of having a defined number, tracking it, reporting it to yourself annually is the important thing. It's what differentiates a practice that says that they're going to actually do something for these people versus the people that actually follows through on it, versus the people that are just using it in marketing language, which is very sad that some practices do that. So practice number 2 is free content that reaches the unreached. So this is the highest leverage form of access most physicians underestimate. A YouTube channel, a podcast, a newsletter, a social presence of any kind, right? Any of these executed at clinical grade quality reaches patients who would never pay for your program, but would benefit from your knowledge. The top ranked aging and longevity influencers in 2026 by published rankings I referenced in the previous episode include physicians like Gabrielle Lyons, Robert Love, Patricio Ochoa, who have built audiences of millions through free content. Whatever you think of any individual figure on those lists, the structure of their work means that the educational content they produce is access to anyone with an internet connection, regardless of whether they can afford the premium service or not. A practitioner who runs a high-ticket practice and produces no free content, in my view, can feel ethically vulnerable, like psychologically. If you're fine with it, that's great, because ultimately you're helping people. You don't need to create content. I've never really created content, but this is a way for you to feel better about what you do. And I'm getting into creating content, by the way, which is why I'm doing this. A practitioner who runs a high-ticket practice and produces serious free educational content has resolved a meaningful proportion of their access objections from distribution alone, and is helping a lot more people, much greater than they could in the traditional system. So practice number 3 is outcome transparency. The operators with their integrity intact publish their outcomes, not testimonials, not before and afters, actual aggregate clinical data, biological age trajectory, biomarker improvements, retention rates, adverse event ratings, the percentage of patients who hit their stated goals. This matters because outcome transparency is the single best defense against the charge that high-ticket medicine is selling the appearance of premium care without actually the substance. So if your patients are demonstrably healthier at the end of a 12-month program than they were when they started, in measurable terms, you have answered one of the ethical questions that ultimately matters the most. Does this medicine work? This is one of the reasons why I'm so passionate about what I'm doing, is because I've done so many pre and post lab tests that I'm like, oh my goodness, this is the most valuable product on the face of the planet. It's for somebody to be able to work with me. And that conviction comes across when I'm in one-on-one conversation with people. So if they aren't, no marketing language will save you. No amount of charity work will compensate the failure of the core product. And this is literally why I built the Longevity Practitioner Certification Program, so that doctors can learn the best information in regenerative and longevity medicine, and so they can walk into these reported findings visits with confidence and certainty that they're gonna get the best results possible with the people that they're serving. Practice number 4 is refusing to overpromise. The practices that lose their soul are the ones that promise outcomes the science can't actually deliver. So reverse your biological age 20 years in 6 months, cure age-related disease, eliminate cardiovascular risk completely. The ethical line in longevity medicine is not the price tag, it's the promise. Operators with integrity tell patients exactly what the literature supports. 3 to 5 years of biological age reduction in 12 to 24 months as well in a well-executed program. Look, if you have data that backs what you're saying, that's another thing. But ultimately, if you don't, you should go back to the literature, right? Meaningful gains in, say, VO2 max. You can share what the literature says about that if you do XYZ. Real reductions in cardiometabolic risk markers. That's a defensible promise. Those are some defensible things that the literature actually says that if you do this, you can get that. So it is also an extraordinary promise compared to what conventional primary care offers. It does not need to be inflated to be valuable, and that's really important. And look, look at the comparison of what who your competitor is. This system that is completely broken. It's completely broken, and it's not getting better to the point where we want it to get better anytime soon. The Berlin Reframe from April, published through Eureka Alert by the World Mitochondrial Society and articulated by Dr. Marvin Edius, is really helpful here. The shift from reverse aging to preserve resiliency is partially an ethical shift. It's a more honest reframing of what medicine can actually deliver, and it gives the practitioner defensible language for talking about outcomes that does not require overpromising, okay? So think about this. You're reserving resilience. You're cultivating and replenishing the optimization of the body versus anti-aging, because we shouldn't be against aging. Aging is a beautiful thing. Practice number 5 is clarity about who the patient is and is not. The patient who generally benefits from high-ticket longevity programs or high-ticket programs in general, they look like this. They have the discretionary income to invest meaningfully in their health span without compromising their family's financial stability. They have the motivation to execute the protocol. They have specific measurable health goals, not vague optimization fantasies. They understand they are buying a 12-month relationship and an outcome trajectory, not a single product. And the patient who does not belong in a $15,000 program or whatever the price is, it could be a $5,000 or $50,000 program, is the patient who is stretching their finances to pay for it to the point where they're gonna go bankrupt or they can't pay it, right? I do believe that if somebody feels that it's a stretch to pay that kind of money, they should still do it. Even if it's stress, get uncomfortable, because it'll bring you to the program more and it'll get you better results. But obviously, if they're to the point where they're going to be out on the street, that's not an ideal situation. So the patients with severe untreated psychiatric illness, obviously, that's not good. Who's using the program as a substitute for acute mental health treatments. The patient who is shopping for a magic bullet. The patient with an active end-stage disease that needs real interventional care. Maybe you could work with them in conjunction with the kind of care that they need. Those are some of the things that we need to be thinking about. So operators with integrity are willing to turn patients away. This is the single hardest practice element to maintain when growing a business, but it's important to maintain your integrity. So the next thing is the self-test. Here's the test I would apply to my own practice annually, and that I would recommend any practitioner building in this space apply to theirs. So there are 5 questions. Answer them honestly. Question number 1, are my outcomes better than what these patients would get in conventional care? If the answer is yes, you're practicing real medicine, real healthcare. If no, you're running a wellness brand with a stethoscope or whatever it is, and the price tag is harder to defend. Number 2, am I extending access in some structured way to patients who cannot pay at the level that other people can? Either group coaching, downsells, or maybe coaching programs with a health coach that they work with for a fraction of the investment. Or maybe you're doing scholarships, maybe you're doing charity slots. You do and create free content, mentorship of clinicians, serving underserved populations to help those clinicians be able to support people. You do some pro bono consultations, whatever it looks like, are you doing some of that? Number 3, am I telling patients the truth about what the program can and cannot deliver? Promises grounded in the literature, presented with appropriate uncertainty, with realistic timelines, and the acknowledgement that some patients will not respond, right? That's important. If your sales conversations would not survive cross-examination by a peer-reviewed panel, your sales conversations are probably a little too aggressive. And number 4, am I willing to turn patients away when the program is not the right fit for them? If the answer is no, if every prospect who can write a check gets enrolled, you have crossed essentially from medicine into commerce, right? And I would highly recommend rethinking your programming. And number 5, am I building something I would be proud to describe to a colleague that I actually respect? And could I do that in detail with my outcome data on the table? If your answer is yes to those 5, the moral objection has been engaged seriously and the practice is defensible. If you cannot, the work is not worth what you're doing, unfortunately. So the reality is most of us are checking all the boxes off here. And the last thing I will say is that, and this is the bottom line, is that we have a moral and ethical obligation to charge what our program is worth and to bring people through to the process of transformation in a way that people can still access working with you and access the strategies and solutions that you're building and developing. I'm building a $1 million program, multi-million-dollar program. I'll have a $5 million program, a $10 million program for one person and families. And so people may look at me and be like, what? You're gonna be building $5 million, $10 million programs for people? Yeah, I am. And I've already built them out. And it's going to be something that's gonna really help these extremely high net worth people of the world transform the trajectory of their health and their life, not just for them individually, but for their next generation. We're gonna transform their generational health. And so I have a complete 100% ethical compass, moral compass that says, yes, this is something that I should be doing. And ultimately, you can always do downsells. You can always work with people that can't afford your care at a high ticket price in a lower tiered program. But ultimately, I hope you enjoyed this. Please share this with your friend, your family, or your friends, your doctor friends, the people in the health space that will help them overcome the objection of this. And I'd love for you to click that bell button. That will remind you specifically about what to do or when new videos come out, and click that subscribe button as well. Thanks so much.